So good morning. My title, which of my patients is a candidate for transplant? My disclosures. Okay, so the goals for today, with an amyloidosis referral in hand, weigh the merits of autologous stem cell transplant and recognize how solid organ transplant may play a role in the treatment of AL. So we'll start with a case. 50-year-old male with a 6-month history of progressive dyspnea sent to you, hematologist, with a diagnosis of amyloidosis involving his heart based on an endomyocardial biopsy. What should you do now? So, A, start daratumumab, cyclophosphamide, bortezomib, and dexamethasone immediately. B, make sure the amyloid has been typed. C, start insurance approval for stem cell transplant. D, all of the above. E, none of the above. And it's a little bit tricky, I think, but we'll see. Oh, it won't let me go forward. There we go. Yes, so you guys were listening to the last talk. Again, this is just so important in terms of you need to type the amyloid. I mean, yes, if it is AL, A is a good answer, and if you're thinking transplant, that's a good idea too, but there's a lot yet to be done. And so that is the correct answer. So just a brief outline of what you do when you have amyloid. The first thing of AL amyloid, you want to make sure it is AL. Then you want to stage the disease and you want to assess the organ involvement. Then you want to think about plasma cell-directed therapy, and we're going to talk a lot about that. You want to get at least a hematologic, very good partial response. And of course, as we're doing this, we are always thinking clinical trials. If you get a hematologic, very good partial response, typically we'll move to observation after we've had adequate therapy. If you don't get a very good hematologic response, and some would argue you need a complete hematologic response, you're going to basically consolidate or consider them, relapsed or refractory rather. And in terms of maintenance, it's not typical to use maintenance in amyloid, with certain exceptions that we'll discuss. So to stage amyloid, simple tests, troponin. Troponin T is what we favor, and NT-proBNP. And on the left is the European modification of the Mayo 2004 system. And basically, if you have troponin and NT-proBNP above the thresholds, that puts them into the stage 3 category. And if it's an ultra-high NT-proBNP, 8,500 or higher, then it gets split into 3A and 3B. And you can see that there's marked difference between the red line, the top curve, stage 1 patients who have everything below threshold, and the 3B who have everything above threshold. We're talking about a 1-year survivorship of less than 20% in the gold line and a 7-year survivorship of about 80% in the red line. Similarly, there's the Mayo 2012 staging system, which uses slightly different cutoffs of troponin and NT-proBNP, but it incorporates the free light chain. And again, really good separation of curves. And so this is really important to understand who is my patient and what is my expectation. So why transplant? So these are data from our institution, pretty mature, looking at 672 transplant patients based on hematologic response rates. And you can see the blue line are those patients who achieved a complete hematologic response, and their median overall survival is over 15 years. VGPR patients, 8.7 years, and so forth. In addition, if you focus in the middle column of this table, you can see that the progression-free survival of patients achieving a complete hematologic response is 146 months or 12 years, VGPR 5.5 years, and so forth. So it has withstood the test of time in terms of being a treatment that if you get a deep response, patients can do exceedingly well. But there's always that question of selection. And so what about that? So I'm going to do something a little bit illegal. I'm going to do some cross-trial comparison, so bear with me, you've been forewarned. But what I have in this table are the results or some of the information from the Andromeda trial, the daratumumab, bortezomib, cyclophosphamide dex versus just the triplet, the VCD. And then I have some transplant information or data. And if you look at the staging that I showed you, stage 1 is the best patients, stage 3 is the worst patients, and you look at the right-hand column, you'll notice that the stem cell transplant patients, 69% in this series, are stage 1. In contrast, only 20-odd% are stage 1 in the Andromeda trial and a lot of other trials. And if you look at also stage 3, only 13% of the transplanted patients are stage 3, in contrast, about a third in the clinical trial patients. And even the TRM, the transplant-related or the 100-day mortality, is only 2% in the transplant group, again, showing selection versus 7% in the conventional treatment. And again, if you look at just CR rates, or hematologic response rates, this is primary analysis from the Andromeda trial. The purple is the quadruplet and the orange is the triplet, and the deeper the color, the deeper the response. So the CR rate for the daratumumab VCD was 53% versus only 18% for the triplet. And if you throw, again, this is just data from our institution, 41% of patients achieve a CR. Most of these patients did not have induction because this is a series of older, patients, and induction wasn't de rigueur back in the day. But you can see that Andromeda definitely is giving transplant a run for its money, though follow-up is very, very short. So the next question is, for whom transplant? So these are our criteria, and I think it's very similar at many institutions. You want patients that are, not too old. You want good performance score. You want a troponin that's not too high. You want reasonable renal function, because the last thing you want to do is transplant somebody with, a low EGFR, and they have renal only, and they go home on dialysis. Now, we do transplant patients who are already on dialysis. We do stem cell transplant if they're thinking we're going to get like a kidney transplant down the road and so forth. Reasonable heart function and typically no more than 2 organs significantly involved. Also blood pressure. If you have a sitting blood pressure less than 90, you want to think twice. But this is why we use troponin as a cut point. These are sort of retrospective data from our institution. We looked and saw what was the break point for bad and good outcomes with stem cell transplant among our patients, and it ended up that 0.06 troponin T was associated with a 25% mortality, in contrast, 4% for patients with lower troponins. So another comment about who might be a candidate for transplant. So these data here are sort of focusing on the bone marrow plasma cells. Remember, patients with amyloid, median bone marrow plasmacytosis is 10%. So half of them look like if you just look at the bone marrow, this is an MGUS, and half of them have plasma cells that would, be, quote, myeloma-like. The idea of these curves is that if you look at no transplant, if you parse the patients based on their baseline bone marrow plasmacytosis, you see that those patients undergoing standard therapies, if they have greater than 20% plasma cells, they actually do significantly worse than their counterparts with a lower plasma cell burden. Some of it is they have more advanced disease at the get-go, but they definitely do worse. And on the transplant side, again, patients who have fewer than 5% plasma cells, which does happen not infrequently in AL, they do the very best as compared to 5 to 19 and 20%. And so, the idea, the plasma cell burden is sort of makes, in my mind, patients more myeloma-like, and thinking that maybe a little bit is not enough. We know from the IFM 2009 trial, which looked at VRD versus transplant, that although overall survival so far is not different, PFS is better when you do transplant in myeloma patients. So a reason, perhaps. And this is just the multivariate of the same study. The 20%, which is on the bottom right, is definitely significant, along with transplant being a good thing for these patients, as well as cardiac stage, and moving to the left-hand side of the slide, the usual suspects, the age, the period at which they were diagnosed, more recent patients typically doing better. So what about induction? Again, I'm cheating and I'm doing a cross-study comparison, but if you look, so Andromeda are the two green first columns. The VRD is work from Dr. Kastridis. It was a collection of patients, and then on the right is the ENM study, which typically I'm not going to highlight because that'll happen later, but basically we don't use much melphalan as induction. We use it for conditioning for transplant patients. But the point here is that the DVCD, VGPR rate 78%, VCD 49%, VRD 82%, the 100-day mortality seemed to be the highest in the VRD, though there were stage 3B patients in that cohort. And it's a reminder for me to just say, use lenalidomide and IMiDs with caution in patients with AL. It's not the same as myeloma. They really can get a lot of toxicity. And if we focus on CR rates, then again, we have here the highest CR rates with the DVCD. So I would argue perhaps that the DARA VCD is a really good induction pre-transplant. What about transplant-related mortality? So this is data from Boston, and it's a really nice report because it includes, it's oldish now, it's almost 10 years old, I guess, but it includes the information that patients with AL can even die during stem cell collection. So 2% of this population died just during stem cell collection. And even stem cell infusion, 4 died, so 1%. And then again, in this more historical series, 9% died just in the 100-day period for an overall TRM of 11%. So patients, if you don't select carefully, or if you just bring patients who are sicker to the table, a lot of bad things can happen that you wouldn't necessarily expect. The good news with TRM is that there is greater selection, and there is, what we're showing here on the left is Mayo data, CIBM TR data on the right, and it's TRM by period. So basically the gray is the more recent period, and the blue is sort of patients back in the late 90s, early 2000s. And you can see that the TRM has definitely gone down from 14-ish% down to 2%-ish, but that is largely due to selection. And the reason for dying, so each of these little pies has the overall TRM per period, but then the little segments are showing you how they or why they died. And you can see that if you focus on the top circle, that in gray, about a third of patients in the earlier period were dying of cardiac causes. As you also, even in the all 2000s, again, a very high percentage, 46% were dying of cardiac causes, which is not what you expect in a usual transplant population, but certainly in amyloid possibly. But then when we get to the more recent with greater care and selection, the number of cardiac deaths are far lower. So the overall is 2%, but of those, only 17% were cardiac deaths. Others were like sepsis and the things you would expect as TRM for transplant. So the next is about melphalan dose, and I would argue that the dose matters. These are some data just from our institution showing the survival of melphalan 200 milligrams per meter squared as conditioning versus attenuated dose for patients with AL amyloidosis. Markedly different. These are data from Boston, and you can see, again, a breakdown of the 200, MEL 200 in the first column, and then MEL 100 to 140 in the next column. So the whole idea of Boston, they had a great idea, Ray Comenzo, when he was there, is, you know what, transplant's good, maybe we can get sicker patients through if we attenuate the dose of melphalan. And indeed, you can get patients through, but you sacrifice a lot. So the complete response rate is almost, half. The TRM is acceptable, it's 14%. If you took those patients and you transplant them with MEL 200, it'd be 40 to 50%. So you definitely bring the TRM down. The event-free survival is about half if you reduce the melphalan dose, and the overall survival is half. Now, some of that has to do with the dose, some of it has to do with the frailty of the patients, but for a CR rate of 24%, do you really need to relocate your patient and bring them through? And then this is just the overall and event-free survival for that cohort. So the next question is, if you do the MEL 140 or 100, can you catch up after with consolidation? And so these are data from Memorial Sloan Kettering, where they took this approach, and you can see in this pie chart that only about a third got MEL 200, and the rest got either MEL 100 or MEL 140. And the plan was risk adapted, give them a lower dose if they're sicker, and then do some kind of consolidation. And so this report is a mix of, there was some thalidomide consolidation because it reaches back to that time period, but bortezomib as well. And you can see that the response went from 28% to 62% with the bortezomib consolidation. And then on the left, it's progression-free survival. On the right, it's overall survival. And you see that if patients have a CR, they definitely do better. I would argue with all the modern therapies we have right now, to put somebody through staying away from home for 6 weeks or whatever and give them a low-dose transplant probably isn't the best thing. I think there are many that might argue that even doing high dose for a really good patient may not be the best thing because we have so many other therapies. But I'm going to move to organ transplant. So here we have kidney transplant for AL, which is very feasible. These are some series, small numbers of patients, because that's what's reported. But the long and short of it is that if you have a patient who is in remission or typically in CR, you can do a kidney transplant and have really excellent long-term overall survival, 5 years, over 80%. So the other is moving towards cardiac. Remember how I showed you the staging system, and you see the European modification of the Mayo 2004 system, and you can see the gold line that their 3B patients are in dire need of help. 80% are dead, in the first year. The Mayo 2012 doesn't use the ultra-high NT-proBNP, but what you can see here is we broke the stage 4 into those with the ultra-high versus not the ultra-high, and the blue line there shows you how dismally these patients do, and the red line, not quite as bad. So if you pick those out of the stage 4, they actually do better. So 44% will have the ultra-high NT-proBNP. And a similar exercise was done for the stage 3, which is useful for clinical trials that sometimes use the Mayo 2012 system. So what about heart transplant? Very limited data in this part of the slide. You can see very old data, publications, 91, 2010, 2008, 2009. These are patients who really did not have very good plasma cell-directed therapy available because it didn't exist, because it's spanning many years. And so, 5-year overall survival ranging from 16%, to 45%. Slightly more recent publications, but also most of them, except for the Houston study, are really spanning long periods of time. And so you can see that the 5-year in Boston was 60%, And then the Houston is 5 years, 77%. So I think, it is a viable option for those patients who can get hematologic response. I do worry in some places that they may be offering hearts the enthusiasm to patients who may not yet quite need it, but it's a hard call. So newly diagnosed amyloid, you basically, I think that you start induction with Daracibor-D, transplant ineligible, and you follow that pathway, and Dr. Kastridis is going to tell us about that. But I would say that at 2 cycles, you don't get a hematologic VGPR. You need to really consider these patients refractory and think of something else. But if they are doing well, you complete the Andromeda trial, which we'll hear more about. If they're transplant eligible, it gets a little harder. I would say, let's do induction with the Daracibor-D, because that's our very best therapy. Collect your stem cells. But what if they have achieved a complete response, or even MRD negative with Daracibor-D? Do you take them to transplant? And I don't have an answer for you on that. All I can tell you is that we have very mature data that, say we have good long-term outcomes in these types of patients. But I don't think anybody could blame you for saying, let's just take them and treat them according to Andromeda. I think that's, who knows. But again, you want to get at least a very good partial response, preferably even a CR. If you don't, you want to give them additional therapy. And typically we observe these patients unless they're very myeloma-like, they have bad cytogenetics or whatever. So we don't typically use maintenance in our practice. So I'd like to summarize. Correct diagnosis is essential. High complete response rates may reduce the use of stem cell transplant. Little role for attenuated dose melphalan for transplant unless they have renal failure or something like that. Greater need for stem cell transplant with patients with higher plasma cell burden and higher risk FISH. Renal, more feasible than cardiac transplant among patients with plasma cell responsive disease because you can use organs from living donors in the kidney situation. And with that, I'd like to thank you for your attention, and I'll take questions later.